Good evening, doctors, and welcome to a new guideline video. Today, we are going to read the Congenital Heart Disease Guideline from the Neonatal Guideline book, the Blue Book, which is duct-dependent lesions, including hypoplastic left heart syndrome and left-sided outflow tract obstruction. Let's start with the introduction. The introduction is talking about the importance of keeping the BDA open to supply the pulmonary or systemic blood flow and allow adequate mixing between the two circulations. We have three categories in duct-dependent congenital heart lesions. It whether mixing lesions such as TGA, and the baby will presented with a cyanosis, a blue baby, or obstruction to pulmonary circulation. For example, pulmonary atresia, tricuspid atresia, fallot tetralogy, critical pulmonary stenosis, and the baby as well will present with cyanosis. The third one is obstruction affecting the left side of the heart, which is obstruction in the systemic circulation. For example, hypoplastic left heart syndrome, critical aortic stenosis, coarctation of aorta, or interrupt aortic arch. And in this situation, the baby will not present with cyanosis, instead will present with poor perfusion and shock. So what's the differential diagnosis of central cyanosis, blue baby, or persistently low SpO2 less than 95%? Okay, so what does it mean, cyanosis, in here? Cyanosis is the abnormal blue discoloration of skin and the mucous membranes. We have a note here in the box saying without echocardiography, clinical distinction between significant persistent pulmonary hypertension and duct-dependent pulmonary circulation can be extremely challenging. So we have the persistent pulmonary hypertension and the duct-dependent pulmonary circulation. They are very, very close to each other. The baby presenting with cyanosis, and it's very tricky to reach the diagnosis. It's really challenging. If cause in doubt, an echocardiogram cannot be obtained, discuss commencing prostaglandin urgently with on-call consultant, as can also be beneficial in BPHN. Okay, so anyway, you are uncertain about the diagnosis. You are not sure whether this is BPHN or it's a duct-dependent pulmonary circulation lesion. You will start prostaglandin, and prostaglandin is very beneficial in the BPHN as well. Okay, so what are the causes? We have cardiac causes, respiratory causes, and other causes. So cardiac causes for central cyanosis, we have mentioned them up there in the box. Duct-dependent lesions, we have know some of them. There's other cardiac conditions like total anomaly, pulmonary venous drainage anomaly, fallot of tetralogy, truncus arteriosus as well. Respiratory causes, persistent pulmonary hypertension, congenital pneumonia, pneumothorax, meconium aspiration, congenital diaphragmatic hernia, and respiratory tract obstruction. The other causes, it could be methemoglobinemia, differential diagnosis of babies presenting with poor perfusion shock. It's basically and literally it's affecting the left side of the heart. We have mentioned them up there. It's anything affecting the left side of the heart, like hypoplastic left heart syndrome, aortic stenosis, interrupted aortic arch, and aortic stenosis as well. Putting all this together with arrhythmia, supraventricular, ventricular tachycardia, and cardiomyopathy. Other causes of shock, you should think about the sepsis, bleeding, dehydration, and metabolic causes as well. So how you can recognize and assess a baby with duct dependent lesions. So we have antenatal diagnosis and postnatal diagnosis. So whether you have known the case antenatally in utero antenatal diagnosis, so your management will be completely different. So if diagnosed in utero, see management plan and mother's healthcare record, deliver at local NNU or NICU, equipped for serious congenital heart disease, stabilized before a non-urgent transfer to original pediatric cardiac center for full cardiology assessment. So you have to plan ahead. Once you know this coming baby have any heart problem, congenital anomaly. So you have to plan ahead for that. And a delivery should be in a local NNU or NICU equipped surface. If urgent septicectomy anticipated for closed or small restrictive atrial septum, cardiologist may recommend delivery at regional NICU, liaise with cardiologists at tertiary center before delivery. So if the cardiologist decided that he would do a septicectomy for this coming baby, so delivery should be at original NICU, and at the same time they have to liaise with a cardiologist at a tertiary center to transfer the baby afterward. The next step, neonatal team meet parents pre-delivery. So neonatal team in general, they should meet the parents, have a chat with the parents, make this thing simple, and they have to be transparent to the parents and tell them everything about the risks, about the outcome of this. In some cases of hypoplastic left heart syndrome or complex congenital heart disease, comfort care plan may be in place antenatally. Clarify with cardiac team and parents before delivery. So comfort care plan is very crucial in here, as some of the or most of the hypoplastic heart syndrome babies do not survive that long after the surgery or before the surgery. So comfort care plan should be put in place beforehand. When delivery expected, notify on call a neonatal consultant, NNU and pediatric cardiology team at local referral center. So when delivery expected, when it's time for baby to come to this world, you have to notify on call neonatal consultant, NNU, pediatric cardiology team. All this is going to be informed. Next page, we have the postnatal. What if the diagnosis done postnatally? Some babies, particularly if left heart lesion developed later in gestation, will present when duct close. So the babies who are diagnosed postnatally, usually they deliver normal way. They are very nice. They spend days very well. Once the ducts start to close, they will start to be symptomatic and manifested and showing distress, and they present maybe with cyanosis or with shock sometimes. Can happen at any time during a neonatal period and early infancy. Baby often asymptomatic before duct close. A baby presenting with cyanosis or shock is a neonatal emergency requiring consultant input. These babies can deteriorate very quick. Okay, so what are the symptoms and signs of duct-dependent cardiac disease? A central cyanosis and or SpO2 less than 95%, poor perfusion and shock, weak or absent femoral pulses, usually limited signs of respiratory distress, murmur, in some cases, hepatomegaly or other signs of cardiac failure. Investigations. You will need to do a chest X-ray. You will look for oligemia, plethora, congenital anomaly, classic appearance, boot-shaped heart is unusual even in fallot of tetralogy itself. But that's what we know so far: boot-shaped heart, blood gas including lactate, echocardiogram if available, blood pressure in right upper limb and lower limb more than 20 millimeter mercury difference between upper and lower limb is abnormal. Preductal right upper limb and postductal lower limb striations, SpO2 less than 95% in both limbs, or more than 3% differences is significant. Modified hyperoxia test, I don't want to talk about it now. I guess it's not used anymore in some countries. If there's respiratory pathology, SpO2 usually raises to 95% or more. So what is the immediate management in this situation? A suspected cardiac baby presenting collapsed, shock, and or cyanosis is a challenge. Neonatal emergency. Discuss commencement of prostaglandin infusion urgently with consultant. Discuss urgently with cardiac center as well. So what's the immediate post-delivery and resuscitation? If antenatally diagnosed duct-dependent lesion, neonatal team middle grade should be present at the delivery place. If baby requires resuscitation, do not delay resuscitation. Check SpO2 using the pulse oximeter. Once stable, transfer baby to NNU immediately and transport incubator. If on saturation, monitor SpO2 75 to 85% should be acceptable for babies with antenatal diagnosis of duct-dependent cyanotic heart lesion. If cyanotic heart lesion is suspected and not confirmed postnatally, manage initially by trying to achieve maximum SpO2 possible. Okay, stable babies with normal breathing and SpO2 75% or more may not require intubation. Okay, and the management in the NNU aim to maintain patency or off or open closed ductus arteriosus and optimize systemic perfusion. That's our main target. Commence prostaglandin infusion as per antenatal plan if known through peripheral IV line or long line. 2 venous lines, access recommended to ensure reliable infusion. Unless access difficult, avoid umbilical venous line because the cardiac unit may need umbilical venous catheterization to do a septicectomy. If multiple infusions inotrope required, discuss UVC with on-call consultant or cardiac team. Okay, next page, saying that use prostaglandin A2, start IV infusion at 5 to 15 nanogram per kg per minute as indicated. Dose may be increased up to 50 nanogram per kg per minute if no response within 1 hour. So if there's no response to prostaglandin E2, 5 to 15 nanogram per kg per minute, you can increase the dose to 50 nanogram per kg per minute. Oral dinoprostone used temporarily on very rare occasions when IV access is extremely difficult. If dinoprostone not available, use prostaglandin E1 instead. Make first solutions every 24 hours. If apnea occurs secondary to a prostaglandin infusion, intubate baby, but do not reduce the infusion dose. Discuss management with cardiac team at regional pediatric cardiac center. Echocardiogram if available. If evidence of hypoperfusion, base deficit more than 5, lactate more than 3, or hypotension or cold peripheries, give sodium chloride 0.9%, 10 ml per kg fluid bolus. And then you have to monitor the SpO2, heart rate, and ECG, blood gases, including lactate, and avoid acidosis. Blood pressure, preferably using a peripheral arterial cannula. Avoid umbilical lines if UAC required. Discuss with on-call consultant. Avoid hypothermia as well. Ventilation, we have the indication for ventilation in a blue baby in here. If intubation not needed as emergency, discuss with pediatric intensive care unit, PICU, or cardiac team. Severe hypoxemia, acidosis, and cardiorespiratory failure, apnea after starting prostaglandin infusion. For those more than 50 nanogram per kg per minute. Features of high pulmonary flow in case of hypoplastic left heart syndrome. Elective ventilation if preferred by pediatric cardiologist or tribal team lead. Okay, that's the indications for ventilation in a blue baby. I will repeat once again. If intubation not needed as emergency, discuss with pediatric intensive care unit, PICU, or cardiac team. Severe hypoxemia, acidosis, and cardiorespiratory failure, apnea after starting prostaglandin infusion, feature of high pulmonary flow in case of hypoplastic left heart syndrome, elective ventilation if preferred by pediatric cardiologist or a retrieval team lead. The technique of the ventilation, I don't think it's very important here. Inotropes, if signs of peripheral underperfusion, discuss using fluid boluses and inotropes such as dobutamine, milrinone with cardiac center. Arrange local echocardiography if available to assess contractility as well. Restrictive atrial septum. What are the signs of restrictive atrial septum? Severe cyanosis, cold periphery, pallor. So there's a cyanosis altogether with cold peripheries and pallor, respiratory distress, X-ray signs of pulmonary edema with relatively normal heart size. In contrast, if atrial septum is non-restrictive, pulmonary congestion with cardiomegaly and prominent right heart border is likely. May require balloon atrial septostomy as an urgent procedure if too unstable for transfer or no beds at cardiac center. Cardiac team may perform as emergency outreach procedure in NU. Last page. If you got high pulmonary blood flow, especially in left-sided lesions such as the hypoplastic left heart syndrome, the presentation is going to be in form of too much pulmonary blood flow going to the lung due to pulmonary steal phenomena. Baby may have high or near normal saturations, metabolic acidosis with raising lactate, low blood pressure, especially the low diastolic, cool peripheries, tachycardia. The management aim to improve perfusion and acidosis by balancing systemic versus pulmonary circulation. Discuss urgently with cardiac center, intubate and ventilate, fluid boluses and inotropes. And the last but not least, there's apparent communication leaflets in here to keep the parents informed. It's important that parents are kept informed and updated regularly during the management. There's a link out there. You can have a look on any leaflets of any cardiac lesion you are looking for, and it's very beneficial for the parents. Thank you, doctors, for watching. I wish you will enjoy this video as well, and pray for me. And please like and subscribe and leave a comment for me down below. If you have any piece of information you would like to add, if there's any, if you don't like the way that I present the guidelines and you want me to improve it, any comments, please do comment for me. I will be so happy to interact with you on the comments. Thank you very much and have a nice day.